have joined this class today, and nice to be with associated with this Department of Distance Education, Puducherry University. And a few years back, this program of MBA Hospital Management, we were active participants in the program. Nice to be back with the university after the COVID pandemic. And today's topic is the healthcare system in India, our country. See, the healthcare system, actually, we had a, before the arrival of the British, we will all know it was the local system of medicine. Now, what we call it is Ayush, like Ayurveda, Siddha, Unani, so on. And after the arrival of the British, naturally we shifted to the allopathic system of medicine. And under the British, lot of hospitals were established, medical colleges got established, and we had adapted our system to the allopathy form of medicine. And we have made great strides in the past 30, 40 years in the healthcare system in our country. But what we have to take note now is, under our Honorable Prime Minister now, again, the importance of Ayush system of medicine, that is Ayurveda, Unani, homeopathy, Siddha, along with yoga and the wellness sort of medicine, that is gaining a lot of importance. Our Honorable Prime Minister is very much interested in this system of medicine, and now we are giving a lot of importance to this system of medicine along with the allopathic medicine which we were following. The other important development which has happened in this decade, I would say, especially after the COVID pandemic, is the introduction of the digitization of the healthcare system. That is very, very important. We have to take note of. Like after the introduction of the COVID vaccination system and other things, we have gone very deep into the digital era. Now we are looking forward to a system where the entire the health system in our country, from the lowest level to the highest level, will be connected through a digitization, which is happening in all the places in our country. And digitization is not only occurring in health, it is also occurring in every other field in our country. And so in the next few years, what we are looking forward to is an system which will integrate the entire health system in our country through the digital mode. And this is going to benefit our people to a great extent. And again, one of the pet projects of our Honorable Prime Minister is the teleconsultation, the telemedicine, which we are developing very fast. So we all know that big share of our population is dwelling in the villages, which may not have all the specialist care which is available for the urban people. But this is going to be set right through teleconsultation. But the internet connectivity, we all know, is being spread to all the villages in our country. So with this help of internet, what we are trying to do in the near future is, we are going to develop a teleconsultation system where a person can get a consultation through the teleconsultation mode, and things can be sorted out in our healthcare system. So with this few opening remarks, let us go to the PowerPoint presentation which we have made for this class. So this PPT is regarding the healthcare system delivery in our country. So okay. So briefly, let us look at some of the statistics which are important to us. First, the population. Now we have touched almost 142 crores, and we should note that this is almost 20% of the world's population. And again, if you consider the people in the age group of 0 to 25 years, it forms nearly 50% of the total population of the entire world. And presently, we have 8 union territories and 28 states. And the sex ratio in our country is 943 females per 1,000 males. The birth rate right now is 16.9. The death rate is 7. The infant mortality rate, which has been greatly reduced, now it stands at 27.6. It means if 1,000 children are born in a year, 27 of them die in the first year of life. That indicates the infant mortality rate. And any country, what it aims is to bring down the infant mortality rate as much as possible. And for Puducherry, right now it is 9. This 27.6 is the national average. If you take the figures for states like Kerala, Tamil Nadu, Puducherry, now we have already reached single digit numbers. And a developed country would like to maintain an infant mortality rate around of 5 or 6. That will help us to become a developed country if we are able to bring down the infant mortality rate to single digits. And the under 5 mortality rate right now is 35. And what is a health system? It is the sum total of all the organizations, institutions, and resources whose primary purpose is to improve health. And let us look at some of the historical background of our healthcare system. Way back in 1864, sanitary commissioners were appointed in 3 major provinces. And then 1896, when epidemic of plague occurred, like what we had COVID now, and 1912, Government of India decided to help local bodies with grants and sanctioned the appointment of Deputy Sanitary Commissioner and health officers. And in 1946, Boer Committee was appointed. This committee, you should remember, this is one of the most important committees which really set up the tone for forming our healthcare system. So Boer Committee did a great work, and under the recommendations of this committee, we have set up all our primary health centers, our community health centers, and other district hospitals. So basically, we follow the Boer Committee report. And after independence, health has become a subject like which some of the aspects will be dealt by the center, but mostly it is a state subject. And the first 5-year plan was made in 51, and 1952 community development program was launched. And after 1958, the Panchayati Raj system came into existence, where the health system was taken up to the Panchayati Raj level. And in 1959, another important committee, the Mudaliar Committee, appointed the health survey and planning committees. And whatever Boer Committee had recommended, they had made improvements to this for strengthening of all the primary health centers. And in 1963, the Chadda Committee was formed, and it gave the basic concept of basic health worker and what are the roles. And in 65 was a Mukherjee Committee, and 67 was Jungalwala Committee, 73 was Kartar Singh Committee, which created the appointment of female health worker and male health worker. And 74 was the Srivatsav Committee, which created the post of village health guide or community health volunteer. And in 81, our country also adopted a global strategy of health for all. And in 1985, universal immunization program was launched. Remember, immunization is one of the most important services which our government of India and the state governments are providing to our general public. Through this program, we have been able to eliminate important diseases like, say, smallpox. Now, 10 years back, we have eliminated polio. Now we are trying to eliminate other diseases like tuberculosis, measles, rubella. All this has been possible. And in fact, COVID also we could manage very well because of the immunization program, which gives regular vaccines to our population. And again, in 1992, you have to remember one important program was started in our country, and that program was called Child Survival and Safe Motherhood. So, in the beginning, I told you our aim is to bring down the infant mortality rate, and another important rate is called maternal mortality rate. That is, how many mothers die during the process of delivery. That should also come down. So this program was launched to improve our infant mortality rate and maternal mortality rate. And now the most important program right now, which is still going on in our country, is the reproductive and child health program, which was launched in the year 1997. This is the most important program now which is going on, I would say. All the other programs are linked to this particular program, which is called reproductive child health program, where children are taken care of by various methods, and the mothers in the reproductive age group are taken care of. So this is the most important program, health program, which is going on in our country right now. And 2005, again, reproductive child health program 2 was launched. And in 2007, during the 11th five-year plan, IPHS, that is the standards which are needed for our primary health centers and sub-centers, was formulated. And 2008, another program, NCD program, that is a program for non-communicable diseases. Now we know diseases like diabetes, heart diseases, hypertension, they are the most important diseases from which our population is suffering from. During the last century, people were suffering from communicable diseases. But this century, people are suffering more of non-communicable diseases. We have been able to control the infectious diseases with the help of vaccines, antibiotics. So now the problem is more of non-communicable diseases. And so we have launched a program for the non-communicable diseases from the year 2008. And from 2013, we have launched the National Health Mission, and RMNCH plus A program was launched. So ours is a union of 28 states and 8 union territories. Each state has developed its own system of healthcare delivery, independent of the central government. But the central government always keeps giving us guidelines. Based on these guidelines, the states have developed their own system of healthcare delivery. And our central government is responsible for policy making, planning, guiding, assisting, evaluating, and coordinating work of all state ministers. So this example, if you have been reading the newspapers, you will find how the central government managed this pandemic. They were giving us all the policy decisions, how to plan, how to execute. Based on that, the state governments have done the work. So we have 3 links now: the central level, the state level, and the peripheral or the local level. So now at the central level, who is in charge? We have the Union Ministry of Health and Family Welfare, which is headed by a cabinet minister and also a minister of state. Maybe we have a deputy health minister at times. And so they have secretaries, additional secretaries, commissioners, joint secretary, and so on. And we have the Directorate General of Health Services. They have their team, and they have three main links: the medical care and hospitals, public health, and the general administration. And we have a Central Council of Health and Family Welfare, where the chairman is the Union Health Minister, members are the state health ministers. And what are the functions? To consider and recommend broad outline of policy regarding environmental hygiene, nutrition, health education. Then to make proposal for legislations regarding medical and public health, to make recommendations to central government regarding distribution of grant. So then states have their own Ministry of Health and Family Welfare, which is usually headed by a health minister, and that have the administrative staff and technical advisors to advise regarding the medical issues and public health issues. Then how at a district level we are managing is, we have a subdivision, we have a tehsil, we have a community development block, we have municipalities, villages, panchayats. So each state has its own system of administrative area. So in our Panchayati Raj system, we have developed the three-tier structure of rural local self-government. We have the Grama Panchayat, we have the Panchayat Samiti, then we have the Jilla Parishad. Gram Panchayat is at the village level, Panchayat is the block level, Jilla Parishad is at district level. Why we should know all these things? This is the system which our health department is also following. So what we have to plan is what things will be done at the village level, what things related to health should be done at the block level, and what actions have to be taken at the district level. So our healthcare system basically functions in this manner. So we have a primary healthcare which is provided at the primary health center and sub-center. And the secondary level of healthcare will be provided at the district hospitals and community health center. And the tertiary level of healthcare will be provided at the regional and central level institutions. So it is very important for us to understand this system of healthcare. So this is the basic system which we follow in our country. So at the lowermost level, you have the sub-center. So if you go to any part of our country, we'll have a sub-center. Hello. Slide is not. Slide is not moving. Sir. Okay. I will correct it. My slide move. ஒரு மணி நேரம் கழிச்சு பேசி பாரு. Sorry for the interruption. I was told that the slides were not moving, so we are trying to correct it. Can anybody tell, are the slides moving now? Any of the participants? Anybody? Now are the slides moving?
Yes, sir.
Sir, now is the slide moving, sir?
Yes, sir. It is moving.
Okay, thank you. Okay. Sorry, initially I was told that the slide was not moving. So we will, okay. Now we are in this slide. And this is the most important slide, I would say, to understand the healthcare system. So it is the primary healthcare, which is provided at the primary health center and sub-center level. Next is the secondary healthcare, which is provided at the district hospitals and community health center. Then we have the tertiary healthcare centers, like the higher institutions, like medical colleges or important hospitals in a district. They form the tertiary healthcare. So the system starts at the level of a sub-center. So a sub-center is there for a population of say 5 to 10,000 people. We have a sub-center. And for every 30,000 population, we have made a primary health center. And then for a 1 lakh population, we are providing a community health center, or you can have a district hospital at that level. And then we go on to have the tertiary care hospitals. And each PHC might have 2 or 3 sub-centers which are functioning under the PHC. So primary healthcare is provided at the level of the primary health centers and the sub-centers. We have already told you. The community health centers, district hospitals, specialist hospitals, teaching hospitals form the next thing. And we have important health insurance schemes like the central government health scheme, employee state insurance scheme. Then there are other agencies which also participate in our healthcare system. For example, the defense services, they have a setup of hospitals, mostly which will cater to the needs of the defense personnel, but will also cater to the needs of the local public. And then the railways also have a network of hospitals, medical colleges, which again contribute to the healthcare systems. And now we have the important private sector. So all along we have been talking about the government sector, but now health is to a large extent taken care of by private players also. And in the coming years, their role will be very important because they add value to our system. So we have private hospitals in the forms of polyclinics, nursing homes, dispensaries, general practitioners, single practitioner clinics. And as I told you earlier, now the stress is on the Indian systems of medicine. Now it is called Ayush, Ayurveda, Yoga, Naturopathy, Unani, Siddha, and Homeopathy. Apart from that, we have our voluntary health agencies, like there are so many. For a Red Cross you can take, and there are other voluntary health agencies which help us to carry on with our healthcare system. And we have a lot of national health programs which are going on. For example, we talked about the universal immunization program, where the immunization needs of our country is taken care of. Then you have the TB elimination program, where we are trying to eliminate tuberculosis in our country. Then we have a program for leprosy. We have a program for malaria and filaria. Now the program is called as a vector-borne disease control program. Initially it was separate. Malaria was separate. Filaria was separate. Now for all vector-borne diseases, we have an important program, the National Vector-Borne Disease Control Program, which takes care of elimination of malaria, filaria, controlling dengue, chikungunya, and other diseases which are spread through mosquito bite or other vectors. So basic this primary health care again at the village level. Two important people who carry on this are the Anganwadi worker and the Asha worker. You would have heard if you go to any village, you have an Anganwadi worker who is taking care of certain aspects of healthcare. And now the most important person who is working at that village level is known as an ASHA worker. ASHA, the expansion is accredited social health activist. That is called as ASHA worker now. So these Anganwadi workers, they form part of ICDS program. ICDS is Integrated Child Development Program. This is basically to take care of children who are less than 5 years old, who are at home, not attending school. So this ICDS program was launched around 1980s, and the program has been going on successfully. And the person who takes care of this ICDS program is usually the Anganwadi worker, and this program, strictly speaking, is not a project of the health department. It comes under the social welfare department. So it is a program which is monitored by the social welfare department. And what are the services which these Anganwadi workers and ASHA workers provide? They provide MCH care. MCH is maternal and child health. So basically, they take care of the pregnant woman, the antenatal services which are needed for the pregnant woman. They arrange for the delivery for the pregnant woman, and after she delivers, they take care of her and the newborn child. And then the other important aspect is the family planning. Family planning program was launched in the 1960s, and it has been going on successfully. Then these ASHA workers and Anganwadi workers, they also motivate our public to take the immunization services. And then the referral service, that again is very important. And they identify who are the people who have to be referred to, say, to a higher level of care. So usually the village public, they come to a sub-center. There they are seen by the ANMs and ASHAs. Then they refer patient, if necessary, to a higher level, say a primary health center or a community health center or a district level, based on the problems the patient is suffering from. And then nutrition and health education, again, is an important part of the Anganwadi workers and the ASHA workers. So we should know something more about the ASHA workers. We try to have one ASHA worker for every 1,000 population. So they take care of the village health, nutrition, then health information, counseling. They keep some medicines also. They provide all the information needed for the sub-center, primary health center. They accompany the pregnant women to hospitals. DOTS provider is, they provide the drugs which are given to people suffering from tuberculosis. And they take part in all the national programs which are going on in the country. And to know about our sub-center, which is the beginning level. Everything starts at the level of the sub-center. It is the peripheral outpost of existing healthcare system. We have one sub-center for 5,000 population in the plains and 3,000 per population in hilly or tribal areas or difficult areas. And these sub-centers are manned by at least one ANM. ANM is the auxiliary nurse midwife, and it can be an ANM or a female health worker, and usually we have one male health worker also. And they provide services in relation to maternal and child health, family welfare, nutrition, immunization, and control of communicable diseases. Now they are also playing a very important role in controlling non-communicable diseases also. They provide basic drugs for minor elements. They are provided with drugs which they dispense for minor elements. And the Ministry of Health and Family Welfare is providing central assistance to all the sub-centers since April 2002. And according to the census on 2014 March, we had 1,52,326 sub-centers functioning all over our country. So coming
Yes,
to
sir.
the primary healthcare level, we have one PHC for 30,000 population in the plain and 20,000 population in hilly areas. They provide an integrated, curative, and preventive healthcare with emphasis on preventive and promotive aspects of life. Probably at the end of this lecture or during my next lecture, we will go on to discuss what are known as Ayushman Bharat Health and Wellness Centers. Now, this concept of primary health centers is greatly changed, and now we have a new concept which is known as Ayushman Bharat Health and Wellness Center. We will come to that later on. So, first, let us understand what was going on till a few years back. But in the past few years, we have made some important changes in this primary healthcare system, and that I will discuss later. And usually, the primary health center is manned by a medical officer who is supported by 14 paramedical and other staff like staff nurses, pharmacists, lab technician, and other field level staff. It acts as a referral unit for, say, 6 sub-centers around the area, and it also has few beds for the patients. And as of March 2014, there were nearly 25,000 primary health centers functioning in our country. So, from the primary level, we go on to the next level, which is the district level. And here, the primary health center now it is referring cases to what is known as the community health center. And for our community health center, the population it serves is around 1.2 lakh in the plains and 80,000 in the hilly areas. And a community health center is manned by 4 medical specialists. Remember, primary health center does not have a specialist medical officer, whereas a community health center is manned by specialists like a surgeon and gynecologist and the pediatrician, and they are supported by 21 paramedical staff and other staff like lab technicians, X-ray technicians, staff nurse, pharmacist. All these technicians are there in a community health center, and it has 30 beds. So a community health center usually has 30 beds with one operation theater, one X-ray, a labor room with all lab facilities. And it serves as a referral center for 4 primary health centers, and it provides facilities for obstetric care and specialist consultations. And as of March 2014, we had 5,363 community health centers functioning in our country. So, one slide is missing here. What happened was around 2005, we started one important program that is called as the National Rural Health Mission. So, many of the programs were going slowly in our countries. To give a push to all these programs, Government of India launched the National Rural Health Mission. So, in a mission mode, we wanted to do everything, and most of the activities of the National Rural Health Mission was to take care of the primary health centers and sub centers. And later on in 2013, our government launched the National Urban Health Mission, because rural health was being taken care of by the Rural Health Mission, whereas the slums in urban areas and other areas which are occupied by people who are poor, they didn't have many facilities to take care of this need. Government of India launched the National Urban Health Mission. And later on, a few years later, we have integrated this National Rural Health Mission and National Urban Health Mission into now what is known as a National Health Mission, which is going on in our country. So the National Rural Health Mission and the National Urban Health Mission, they have been combined, and right now what is existing is the National Health Mission, which takes care of the basic needs of our population in all our states and UTs. So,
Sorry
some
for the
details
interruption.
about National Health Mission, the financing components, which we need not worry about now.
So the slides are not getting changed.
Slides are not changing, sir.
Yes,
Okay,
sir.
correct. Yeah, ma'am. Slide show தானே போட்டிருக்கோம். Sir, now the slides are changing, sir.
Yes, sir. Now it is changing.
Now, are they changing, sir?
Yes, sir. Yes, sir. Now it is changing.
Okay. So, what are the challenges for us in our healthcare delivery? One is our population. The next is the increased burden of disease. Now, especially the non-communicable diseases, and then the low percentage of GDP which is spent on health expenditure. Now we will go to a different set of slides. அந்த மூணாவது பண்ணி அதை போடும். Sir, are the slides changing, sir? Sir, anybody can respond now. Are the slides changing?
The slide is now slide number 1, sir. Can you please move to the next slide, sir? We'll confirm whether it is changing.
Is it changed, sir?
So it is still in slide number 1, sir.
Okay, I'll find out, sir. My then திருப்பி இதுவும் slide change ஆகல. Stop sharing என்ன இருக்கு?
அது கொடுக்கல சார். ஸ்டாப்னா ஸ்டாப் ஆகும் சார்.
Yeah. சரி, இப்போ போடுங்க, திருப்பி போடுங்க. அப்படியே இதை மட்டும் மாற்றி பார்ப்போமா? ஃபுல் இது போடாமல். Sir, has it changed, sir?
Yes, sir. Yes, now it is changing.
Okay. So now past few years, sir, this concept of primary health centers, sub-centers, now everything has undergone a sea change. Now the government of India has one important change that is called as Ayushman Bharat Health and Wellness Center. Now we have started calling our primary health centers and sub-centers as PHC, sub-center like that. Now we have developed them into what are known as health and wellness center, because the concept is all along we have been only concentrating on diseases, patients, but now we have realized that we should look beyond that. So more than treating patients and diseases, we should look to methods which will prevent diseases, which will keep our population healthy, and we have to think of aspects like yoga, naturopathy, which will promote the health and well-being of the individuals of our country. So there has been a sea change in this concept, and now this concept is known as Ayushman Bharat Health and Wellness Center. Now a PHC or a sub-center is not called as a primary health center or a sub-center. On the other hand, now we have started calling them as health and wellness centers, and we have designed a system where they have to take care of certain aspects of the health of our population. So now we will go and see what this Ayushman Bharat Health and Wellness Center are. And I think if I have seen your old textbook which was prescribed for your course, this may not have the Ayushman Bharat and Health and Wellness Center concept in the textbook. I am not very sure. And I think I'm sure this will be added in the future textbooks. But it is important for you to know that this is the system which is being followed right now. And we have started using this concept of calling the center as only a primary health center or a sub-center. So now what exists today in our country is basically a health and wellness center, and it is called health and wellness center, sub-center, health and wellness center, primary healthcare center. Okay. So what is envisaged here is to deliver expanded range of services to address the primary healthcare needs of the entire population in the area, expanding access, universality, and equity close to the community. The emphasis is on health promotion and prevention. Not only prevention, here health promotion is also important, like teaching people about healthy food, health, educating them regarding the importance of yoga or other methods which will not only prevent disease, but we want to promote health. And we have to bring a healthy behavioral change in the community, which will reduce the risk of developing chronic diseases and morbidity. So I hope you understand this concept of a health and wellness center. And what is the idea? We want to transform all the existing sub-centers and primary health centers to health and wellness centers to ensure universal access to an expanded range of comprehensive primary healthcare services, ensure people-centered, holistic, equity-sensitive response to people's health needs through a process of population empanelment, regular home and community interactions, and people's participation, enable delivery of high-quality care that spans health risks and disease conditions through a commensurate expansion in availability of medicines and diagnostics, use of standard treatment and referral protocols, and advanced technologies. Remember, we want to use advanced technologies now. Instill a culture of team-based approach to delivery of quality healthcare, encompassing preventive, promotive, curative, rehabilitative, and palliative care. During our next class, we will look into the aspects of this rehabilitative care and palliative care, and ensure continuity of care with a two-way referral system and follow-up support. So one thing you have to understand, now we refer a patient from a primary health center to a community health center. or to a district hospital. It doesn't stop with that. Now, the district hospital or the community health center which has treated this patient, they should refer back this patient to the primary health center and keep the medical officer who in the first place referred this patient to them, so that it will be a two-way referral system. This is very important. Earlier it used to be a one-way referral system. We refer and we forget. So that can't be the situation now. So if a patient is referred, he has to go to a referral hospital and come back to the original hospital where he was referred, so that his treatment will be followed up. And then emphasize health promotion, which includes school education, individual-centric awareness, and promote public health action through active engagement and capacity building of community platforms and individual volunteers. So implement appropriate mechanisms for flexible financing, including performance-based incentives and responsive resource allocation. So what is this performance-based incentives? See, all these ASHA workers, they are not given a regular pay. They are only given a small amount of money, which is only just to give them some support, but they will receive what is known as performance-based incentive. So, say, depending on the number of pregnant women they have helped to conduct delivery, or the number of patients they have referred to a referral center, based on this, every month they are given incentives. So, this is how the ASHAs are being paid now. So, this will encourage them to perform better. And then to enable the integration of yoga and ayush as appropriate to people's needs, facilitate the use of appropriate technology for improving access to healthcare advice and treatment initiation, enable reporting and recording, eventually progressing to electronic records for individuals and families. So this is the direction in which we are progressing. We want to have electronic records for every individual, for every family, so that the treatment will be easier to be carried out. So, for example, a person who has fallen ill on his visit to some other state, if he has an electronic record, it will be very useful for the treating hospital to get his previous health records. So, this is the direction in which we are progressing. And institutionalize participation of civil society for social accountability. Partner with not-for-profit agencies and private sector for gap filling in a range of primary healthcare functions. Facilitate systematic learning and sharing to enable feedback and improvements and identify innovations for scale-up. Develop strong measurement systems to build accountability for improved performance on measures that matter to people. So these are the key elements. I think we will stop with this and continue in our next lecture, which comes up on Thursdays, coming Thursday. If anybody has a doubt, you can ask now, or if you put it in your chat box, we will be able to answer your doubts. Sir, can we stop now today, sir, for today? Anybody wants to clear any doubts which they have? Any doubts anybody would like to clarify at this point, or we can clarify it during the next lecture? Okay, then we will close this lecture today and we will continue on Thursday. Thank you very much for participating. Have a nice day.
Not audible, ma'am. Hello, ma'am. Your voice is not audible, ma'am. You're muted.
Hello, Savita ma'am. Ma'am, your voice is not audible.
Ma'am, your mic is off now.
Savita ma'am, nothing is audible.
Good morning, everyone. Can you hear me? இப்ப கேக்குதா சார்? Sir, can you hear me? கேக்குதா சார்?
Yes, ma'am. Now it is audible.
Yeah, thank you so much. Sorry for the disturbance. Good morning, one and all. Today, let's see about the Transplantation of Human Organs Act. I'm Dr. Sabita, Associate Professor from DSU, Trichy, and from Department of Pharmaceutics. Today, let's see about the Transplantation of Human Organs Act, which is mainly proposed for controlling the illegal transplantations of organs and human trafficking, all those things, and illegal money collection for human transfers, organ transplantations. Nothing but we'll start with the introduction. That is, transplantation of human organ is a mainly very big success in the science field right now, and due to the many technology in the medical field, we are able to transplant in our body organs, which is made up of tissues and organs. Various organs, around 11 organs can be transplanted from one individual to the other by getting an authorized permissions and authorization certifications. It has helped in saving various lives by which the people who have suffered to because of the organ failures, because of single organ failures, most of the people died since many years. Now, due to this science technology, it's very helpful for us to save lives, and it's according to the unofficial statistics from India, it indicates that there are nearly 300 deaths every day due to organ failures, due to lack of organ donations, and this is more than a lakh per year. More than 1 lakh persons died due to the organ failures. And in medical terms, what does this transplantation means? That is that a process in which the either a portion of or a part of the body or a complete organ is transplanted from one individual to the other by getting an authorized permissions. That is the transplantation. The chronological events behind this act is that is this the human organ act was passed by the House of Parliament, that is Rajya Sabha and Lok Sabha. Rajya Sabha proposed this law by 5th May 1993, and Lok Sabha has done this on 14th June 1994. Many amendments were passed after that, and transplantation of human organ rules were proposed in 1995, and transplantation of human organs bill was passed in 2009, and also new amendments were passed in 2011. We have to come across these definitions in this act. To learn this act, we have to come across certain definitions. We also see that now, that is Transplantation of Human Organ Act. That is nothing but this act is mainly provides the regulation of the removal, storage, and the transplantation of human organs for therapeutic purpose. That is, therapeutic means for treatments and for prevention of commercial dealings of human organs and tissues. This law is mainly for regulating, that is, without any regulation, these acts cannot be passed to the everyone cannot simply we cannot transplant or donate any organs to the other persons or any relatives or friends. There are act, and according to that we have to follow the rules, and we have to get authorization certifications from the various authorities and experts and committees. Tissue. Next is the tissue. That is a group of cells which is made up of fully cells, is the group of cells which makes an organ. We have many organs in our body which functions in a different particular functions. It performs the different functions in our body. Next, we have to learn about a very important term, that is brainstem death. Brainstem death is that means the stage at which all the functions of the body is ceased or fully permanently stopped, that is irreversibly ceased, where we cannot come again, we cannot get our consciousness back, but our body organs will be in a fine condition so that we can transplant our body by getting the authorization from near relatives or any authorized specialist or experts. Next is the transplant coordinator. In every hospital, that is multi-specialty hospitals or well-developed hospitals, will have a transplant coordinator who is a person appointment by a hospital or who coordinates all the matters relating to removal or any transplantation of human organs or tissues. This person will be there in a highly specialty hospitals and also in a government hospitals and other NGOs or anywhere. All the hospitals will have a person that is like PRO. The organ transplant coordinator will be there, who will be responsible for coordinating the patient with the doctor in case of human transplantation and organ transplantation and the removal of organs. Human organ retrieval centers are there in all over India. That is nothing but hospital with adequate ICU facilities but not registered under the Human Organ Act. Either they'll have all the facilities and they are not registered, or the hospitals registered under the Human Organ Act. What is the need for this act? At present, only 1% of all donations are cadaver. That is after death. Before and after death, donations are there. That is removal of organs before and after death. 95% they donate kidneys. That is kidney and liver transplantations are from living donors. Those who live, the mother will be giving to son, or son and daughter will give to father, or any near relatives will be used for transplanting when they are alive, they have two kidneys, they can transplant it to, they can donate one to their loved ones or affectionate ones or any nearly, that is blood relationship persons. That is the list of potential recipient is mounting day by day and year. There are many people are waiting for the organs. That is because of organ failures. They are in a waiting day by day. Many people are increasing due to the lack of organs and donors. 95% of kidney and liver transplants are from living donors only. So the person who are willing to donate, that is a big thing, that the person or relative, close relatives, house, that is spouse to the husband, or in a husband to a wife, or daughter or grandchildren's to their grandfathers, like that, where healthy donors can donate to their near relative persons. Then 5,500 kidney transplant in 180 centers, around 400 livers in 25 centers, and 10 to 15 hearts in very few centers are done annually. Mostly kidneys and lungs are transplanted from our India. That is a high rate of kidney transplantation and liver transplantations are done in a very few. Heart and pancreas transplantations are done. Around to coordinate all these things, we need an act and regulations to perform this in a proper way. Around 3,000 patients die every year due to lack of timely organ transplant surgeries. Even if a person died, there is no proper persons to come and transplant, or no experts or specialists in all the parts of the India or any villages. The persons who are willing to transplant also, there is no timely help. That is 24 hours. Within 24 hours, they have to collect the organs. So that proper message is not passed to the government or any organizations.
Lola இருக்காது எதுவுமே இல்லையே.
Ma'am, can you hear? Organ donations from dead body is the mesicule, that is very minimum 0.5 per 1 lakh. Only 2 persons organs are donated by
துர்கா மேடம் ஐடி 37 உங்ககிட்ட இருக்கா? ஐடி 37 என்கிட்ட கொடுத்துட்டு இப்பதான் உள்ள வாங்குனீங்க கரெக்டா?
Excuse me, ma'am. Then some gross imbalance between the new patients being added for transplant and available donors. That is the main need for this act. Organs that can be transplanted are around 11 organs are approved for transplanting nowadays. That is, organs that can be transplanted are heart, kidneys, eyes, livers, and pancreas, intestine, and thymus. And tissues includes skin, bone marrows, tendons, valves of the hearts, and also veins. The heart and kidneys are very vital organs, which is mainly needed for most of the older peoples are lack of kidneys, and even youngsters like 40 years or 30 years are suffering from kidney failures nowadays, and they are waiting for the organ transplantations. So these are the main organs which can be transplanted from one individual to other by getting authorizations. Main aim to propose this act is regulation, removal, storage, and transplantation of organs for therapeutic purpose, that is for treatment purpose, and also prevention of commercial dealings in human organs. The major problem in this act is brainstem death not recognized by Indian law. There are not more experts or neurologists or any medical team is not in abundance in our India. Due to that, brainstem death is not recognized, so that organ transplantations are very less in our country. And rampant trade of human organs, especially kidney trading, is more illegal selling of kidney and taking kidney from the body of the person or patient without unknowingly, without any concern. This is very much high in our India. Due to that, act is passed. There are various laws of transplantation, that is nothing but organ transplantations law does not allow exchange of money between the donor and the recipient. Actually, nowadays brokers are there to get money from the person, and they are selling for even for studies or hospital spendings or family running. They are selling their kidneys. Nowadays, many hospitals are hiring a brokers, and they are getting the kidneys from the very poor peoples. To overcome this situation, the laws are passed for controlling these things. Organ transplantation law does not allow the exchange of money between the donors and the recipients. According to this act, the unrelated donors have to file an affidavit, that is in the court of magistrate, stating that the organ is being donated out of affection. Only a near relative can donate to the patients. Other than that, the person who are willing to donate to their loved or affectionate persons or friends or any unknown persons trying to donate for any known persons, if it is so, then they have to get the approval, or an affidavit should be got from the authorities. The contents of this act that contains this, that is preliminary and authority for removal of human organs. They have to get such approvals. That is, from regulation of hospital should be done, an appropriate authority should be authorizing these things, and registration of hospitals. The hospital which is going to perform the transplantation should propose the license and registration every year, so that the appropriate authority will be going and auditing them every year, and they'll provide the license for them to perform the transplantations and to remove the organs. Offenses and penalties and miscellaneous we are going to see in this. The main salient feature of this act is to regulate the hospitals involved in the transplantation of human organs and to prevent commercialization. Mainly, these are done for the money's sake, that is the commercialization. Two authorities are mainly found, that is a board or committees, that is two authorized committees or authorization committee, AC, and other is a appropriate authority. If a person is donating, he should be a major, that is above 18 years, or he should be an authorized donor, either he should have a brain death or anything, or he should be a near relative. These are the three appropriate authorities for donating the or removal of organs. Appropriate authorities, we can see the central government shall appoint, either central government or state governments will appoint the persons of appropriate authority persons, that is from the either one legal advisor or medical experts, legal experts, and NGOs, and also social workers and experts and neurologists will be in this committee as appropriate authorities. Functions of these people, that is appropriate authority board peoples, is to grant a registration or renew registration. Either they have a powers what they have is appropriate authorities have is to either they will grant the registration or renew the registration, or they will suspend the registration, or they will cancel the registration, to enforce standards for hospitals, and also to investigate any complaint of breach. Breach is they are crossing the limits of the hospitals, that is the service and everything, that is medical law. They are they are neglecting the medical law, that is to investigate and complaint of breach, and also to inspect hospitals periodically for examination of the quality of transplantations, and to follow up the medical care of persons. They should check for these persons have a power to check whether the hospitals are fully maintained properly, transplanted maintained properly, whether they store the organs properly, whether they transfer the organs properly, and also to follow up the patients after the transplantations, how they take care. All such things will be followed by the appropriate authorities. Removal of authority for removal of human organs. Any donor may, in such a manner and subject to such conditions, may, that is prescribed or authorized or removed before its death of the human organ for the therapeutic purpose. Only for the treatment purpose they should remove the organs, not for commercialization. If any donor had in writing in the presence of two or more. There are many organizations, even in online we have websites that we can go for donating the human body and organs, eye donation, blood donation, everything we can enroll our names by online also nowadays. If we are doing that, they will be providing us a donor card. After our death, or even when we are living, we are eligible to donate any parts or body, and removal of body can be done with a certification and authorization. Regulations of hospitals. If a hospital has a authority to transplant the organs or remove the organization, they should follow certain conditions, and they should have a certain license and registrations. No hospital, unless registered under this act, shall conduct or associate with or help in the removal, storage, or transplantation of any human organs. And also, no medical practitioners or any experts or any persons or conduct a cause or conducted or any aid in the removal or placing or replacing or transplanting this organs without any registration. They cannot do under this act, according to under the act. Regulation of hospitals. No donor and no person empowered to give authority for the removal of any human organs shall authorize the removal of any human organ for any purpose other than the therapeutic purposes. Only for the therapeutic purpose, a donor can donate it to the recipient with authorized signatures, and human organs should be removed only for the purpose of therapeutic purpose. No registered medical practitioners shall undertake remove or transplant of any human unless he has explained in such a manner as may be prescribed all possible effects. After prescribing all the possible effects, either by giving an antibiotics or injections or making medications for long time, no other go. So at that conditions, we can go for the transplantation. Initially, for money or commercialization sake, we should not go for the transplantation. Punishment for the violation of this act or this law. Whoever carries out removal of the transplantation without authority is punishable for up to 5 years and around 10,000 of fine. Now enhanced to 10 years and 5 lakhs in transplantation of human organ bills. That is a new amendment from 2011. Further punishments are offending registered medical practitioners is liable to be removed from the state medical council for 2 years for the first offense, and permanently he will be removed for any subsequent offense if he involves in the same thing for further years. Next is commercial dealings like indulging in monetary transaction for trading in human organs, that is brokering the human organs. There are many brokers or private brokers are available who will be in a contact with the hospitals, and they will provide the kidneys or anything for low amount, and hospitals will be commercially charging more from the patients. So in such conditions, if they are caught, imprisonment will be ranging from around 7 years, and 10,000 to 20,000 was the previous thing. Now it is enhanced from the amendment 2011, that is the 10 years of imprisonment, and 20 lakhs to 1 crore is the money should be paid to the government. And punishments for contravention of other provision for provisions where no punishment has been prescribed, that is imprisonment of up to 3 years and 5,000 rupees. The procedure as per law for related donors, the relative who are allowed to donate are direct relatives, that is nothing but a mother, father, or a son or a daughter, a granddaughter or a grandson, or a sister or a brother, or a grandparents like grandfather or a grandmother, who are included in the recent amendment, that is 2011. In the event of there being no first relatives, the recipient and the donors are required to seek special permission from the Government Appointment Authorization Committee. That is, those who are willing to donate as of affection can get the permissions from the authorized permission from the committee, that is AC committee, we can get it. The procedure as per law is for unrelated donors. What the unrelated donors should do means they have to file an affidavit in the court to a magistrate stating that the organ is being donated out of affection. Then undergo number of tests before the actual transplant takes place. Their blood groups should be matching always, and the many tests will be done before the organ transplantation. The authorized committee set up for the purpose ensures that all the documents required under the act have been supplied. And also, if it is found that the money has been exchanged in the process, then both the recipient as well as the donor are considered as prime offenders under the law. Once they are concluding that they are giving for affection and they are getting paid after that, means if it is found, then they are the prime offenders under the law. The few of the amendments are to rename the act as a Transplantation of Human Organs and Tissue Act, and also to expand the definition to the term near relatives to include grandparents and grandchildren, to provide for the enucleation of corneas by the trained technicians, that is by ophthalmologist and neurologist, to provide for the to enable a surgeon, physician, and an anesthetist, intensivist to be included in the medical board in the event of non-availability of the neurosurgeon, neurologist for certification of brain death. Very few specialists are there in India for finding the brain stem death. So there should be more surgeons and physicians should be included to this committee. To make it mandatory for the ICU treating medical staff to request relative of brain dead patients for organ donations, to provide for swap donations of organs, and also to empower the central government to prescribe the composition of authorization committees, and to empower the union territories. Also, this law is only not for Indian states, also to the other union territories also this includes. To regulate the transplantations of organs for foreign nationals. Even the person who is willing to transplant from the other country, or the person from India transplanting to other country, should be regulated. To prevent the exploitation of minors, the person below 18 years are not eligible for transplantation. To overcome the child abuse and child organ trafficking should be avoided, to prevent the exploitation of minors. To provide for the establishment of advisory committees, that is nothing but for appropriate authorities. To vest in appropriate authorities the power of summon persons seek production of documents. The main work and works of appropriate authorities are to provide all the needed proper documents and to issue warrants, and also they have a power to provide summons. To establish a national organ retrieval banking and transplantation networks. There should be more tissue banks and organ transplantation banks should be in all the cities. To provide for the development and the maintenance of national registry of the recipients of organ transplants. To create the position of the transplant coordinator in all hospitals registered for organ retrieval or transplantation. Many hospitals in cities are not having any transplant coordinator. So it is must to increase the positions of transplant coordinator in all the cities. To provide for the registration of non-government organization, that is NGO organization who are willing to donate should be invited with they are also should be added in the organ retrieval camps for the transplantation purpose. To enhance the penalties under this act so that the illegal and commercialization will not occur more, so that to enhance the penalties under the act. To expand the rule making power of the central government. To expand the rule making powers of the central government is nothing but both central government and state government should authorize this. Let's see the case study, one of the case study of this, that is nothing but unrelated donor versus authorization committee. Once there was a authoritative committee had rejected the application from organ donation by a sister-in-law petition. That is, this person does not comes under the near relative. Since she is a sister-in-law, they have opposed to organ transplantation. The prospective recipient filed a written before the High Court for Karnataka against the order of the AC, that is Authorization Committee. That is these petitioners seek direction to the respondents to give clearance for the transplant operation. Reasons recorded by the AC for refusal is donor is not a direct relative. She is a sister-in-law, was not genetically related, and also near relatives were not being considered as donored by the family. So due to this reason, sister-in-law was refused by the committee, AC committee. Final court decision was direction was received to the first respondent that to consider the application of the petitioners afresh. That is, committee has allowed them to donate the kidney for the affection and attachment. Outcome is, when presented with the provision of the law, the AC conclude that if the recipients and donor pledge affection in front of them, they should not object unless there is a complaint or some gross oversight. That is, finally, permission was granted by the AC for the transplant. By concluding this, the importance of this Human Transplantation Organ Transplantation Act 1994 is to control the illegal organ transplant and trafficking, and to stop commercial dealings in organs, especially kidneys, and to accept brain death as a definition of death, and also define donor eligibility, that is not below 18 years, and prevent manipulation of lower socio-economic classes, and also regulate and respect self-willing donor wishes. So by this, we'll conclude this session and we'll check the small statistics regarding the donation. That is, kidney is being transplanted more, and then liver, and very few heart, and very less pancreas and lungs, intestine, and also bone marrow is also transplanted very less in condition. Thank you. Thanks for listening this act. And if any doubts, please you can post your doubts in the box. Any doubts? This is the first topic I have concluded, and now next we have to see the medical negligence, next topic. So before that, if you have any doubts or anything, any queries, please send me the questions in the box so that I can clear your doubts. My students, if you have any doubt, you can post it in the box, or else you can take a 5 minutes of break and you can come back so that we can see the Medical Negligence Act. Thank you. Thank you for cooperating. Good afternoon, one and all. Hope you all are back from your break. Next topic to be continued is medical negligence. Shall we start the session? Is it viewable? Can you see the slides, please? Anyone, please respond.
Yes, ma'am.
Okay, thank you, sir. Yes, the topic now we are going to see is the medical negligence. It's nothing but medical negligence. It is an act. It is a mainly the. It is not a malpractice or anything. This is confused always with the malpractice of medical malpractice. This is mainly the omission in the treatment. That is omission in the treatment of the patient by a medical profession which deviates from the accepted medical. That is,
It's not audible, ma'am.
it's not audible. One second, sorry. Can you hear me?
Yes,
Not
ma'am.
audible.
Not audible?
Yes, ma'am. Now what?
Audible. Audible.
Yes, ma'am. Thank you, please. Medical negligence is a law which is mainly for the omission in the treatment of patients by the medical practitioners. This medical negligence law is mainly for the medical practitioners and other malpractice doing people who is acting like doctors or in a who are not concerned about the patient's life. That is the medical negligence law. That is in this often confused with the medical malpractice, when in fact negligence is only one aspect of the meritorious medical malpractice claims. That is nothing but those who are not a registered medical practitioner and those who are not registered in the state council of medicine are also considered to be under this medical negligence law. They also should be punished or amended under the this law. That is, in terms of medical practitioner tort law, medical negligence is usually the basis for the lawsuit that is demanding compensation for a injury caused by a caused the patient by a doctor or other medical professionals, while negligence or its own does not merit a medical practice claim compensation for an injury. That is, if they have a surgery in the left side and they have done in a right side, or instead of pancreas they have removed the kidney, like that many uh, illegal doings or unattended doings by the medical practitioners will comes under this medical negligence. That is the improper care for a patients by a medical practitioners. That is the medical negligence. That is, this is for the doctors, dentists, nurse, surgeons, or any other medical professional performers their jobs in the way that they deviate from the accepted medical standard of care. That is, they deviates from the proper service or medical practice. According to the law, they will be taking many oaths for medical peoples and with the service minded. For commercialization, they'll do the, or in the unattendedly, they'll do some mistakes and they'll be under this, caught under this law. If a doctor breaks the rule regarding how to treat a patient and does something that is against the rules, then the doctor has failed to perform his duty and is said to be negligent. Types and examples of medical negligence may or can occur in the infinite number of ways. That is, instance of medical negligence can be grouped into following categories. That is, treatment failure or in the timely manner, they won't do the treatment or surgery in the timely manner due to the death of the patients will be there, or the severeness of the disease or symptoms will be increased due to the negligence of the uh, medical practitioners, and also timely manner anesthesial error method medication or a prescription error also due to the negligence of the medical practitioners. Tort law, that is the a civil wrong sometimes also considered crimes that is governed by the state law. common law doctrines designed to prevent harm or compensate for harm of a person primary aim. That is to provide relief through compensation to injured parties for the damages incurred. That is, by the damage incurred to the patients will be compensated by the hospitals or doctors. There are three types of medical negligence in our society, that is criminal negligence, civil negligence, and negligence under Consumer Protection Act. This negligence, medical negligence, also comes under the Consumer Protection Act only. So there are three types of negligence by the doctors or medical physicians or any dentist or psychiatrist or any medical practitioners who are neglecting the patient's health are called medical negligence. Some of the laws or amenities that is followed are duties of the medical practitioner in law. That is given by the Lakshman Balakrishna Joshi, that under the law MANU, it was held that is implied undertaking that the doctor is possessed of skill and knowledge for giving medical advice and treatment. Duty of care is deciding whether to undertake the case. Duty of care is deciding what treatment to give, and duty of care in administration of treatment. These are the certain rules should be followed by the medical practitioners. Nature of the medical services within purview of this Consumer Protection Act is all kinds of services that is rendered by the medical practitioner, except which under where such services are rendered free of charges to all, and contract of personal services with ambit of service. These things comes under the Consumer Protection Act. Contract of personal service cannot be assumed in absence of relationship of master and servant. And also hospitals where medical services are rendered free of cost to all, held not within a purview of this law. Payment of token charges will not alter nature of service rendered by the such hospitals. Some of the nature of medical services within the purview of this consumer law is they should not collect more for more amount for the token charges, and also they should not collect token for waiting and sending the patients in front and back in the queues to quit the queue. They are paying monies to the medical practitioners. Wherever the charges are collected from those patients who are able to pay, those hospitals are covered under this act. And medical profession within the ambit of the Consumer Protection Act. That is, in 1995, the Supreme Court decision in Indian Medical Association with versus VP Shanta ma'am is that brought the medical profession within the ambit of service as a defined in the Consumer Protection Act in 1986. This defined the relationship between the patients and the medical professions as contractual. That is, contractual means that should be somewhat mutual as well as with care and protection. They should save the life of the patients. Then the service is defined under the CPA as service of any description that is made with the potential users, and that not limited to the provision of facilities. That is, in connection with banking or board or lodging or both, housing, construction, entertaining, that such things should not be does not include the rendering of any service of charges should not be included, and under a contract of personal service. Three ingredients of tort of negligence that are breach of any of the duties, that is crossing the duty limits, that is the breach. That right of action for negligence of the patients, a civil action for tort of negligence will be filed against the medical practitioners. To establish the tort of negligence, three ingredients are essential. X owed a duty of care to the Y, that is patients to the doctors to the patients. Doctors' acts or omissions constituted breach of those duties. That is, those who are neglecting the taking care of patients, that is breaching their duties, leading to an injury or damage to the patients. The medical practitioners who are making or hurt or they are damaging the organs or anything to the patients for the personal suit is called the is also comes under the medical negligence and leading to an injury or damage linked between the breach of the duty and the harm. It must be shown that the harm was not too remote. Deficiency is services under the Consumer Protection Act. They are deficiency in service and determination about deficiency in service for the purpose of section 2 is to be made by applying the same test as applied in an action of damages for negligence. If the patients are over anger and they are beating the doctors and also damaging the materials from the hospitals and also comes under the medical negligence and consumers and complaints from the doctors or from the complaints of from the patients or from the relative of the patients who will be harmed or uh, got any harm or any type of injury from the medical professional side will also comes under the this act, and there are many services are in the deficiency for this. That is the consumer defined under the section 2. It means the person who hires or avails of any service for a consideration which has been paid or partly paid and partly promised or any beneficiary of such services with prior approval but does not include a person who avails the service for any commercial purpose will also comes under the Consumer Protection Act. And also the complaint under the section 2 means a consumer, any voluntary consumer association or central government or state government or more consumers, and in case of death of a consumer is legal hire or representative will also comes under the CPA Act. Issue of informed consent, that is a consent should be provided and received from the patients in case of any clinical trials or any medications or any surgery or to be held for a patient. They should give the consent form and get the consent from their family or near relatives or anybody. In addition, the Act also passed to create the rule of reasonable reliance by the claimant on the professional judgment of the defendant, and where a person is so placed that others could reasonably rely upon his judgment or in the skills or careful injury, and a person takes upon himself to give information or advice to allow his information or advice to the duty of the care will arise. Then main thing in this law is nothing but Bolam test, that is it applies to all the acts and omissions constituting diagnosis and constitutional consequential treatment, and Headley Bain applies to all advisory activities. This Bolam and Headley Bain tests are mainly applied for this medical negligence law involving the communication of diagnosis and prognosis, giving of advice on both therapeutic and non-therapeutic options for treatment, and also disclosure of relevant information of both informed consent. The patient should know that we are providing such medications and also we are providing such treatment, such surgery is going to be held for, such organs should be removed. So such things should be, consent form should be informed before the surgery or any treatment should be done to the patients or his close relatives. CPA, that is the Consumer Protection Act and the redressal forums. To provide a simple, speed, and inexpensive redressal of consumer grievances, the Act engages a three-tier quasi-judicial machinery at the national, state, and the district levels. We cannot go on directly apply for the national or state level. First, we have to approach the district levels and then to state and to the national, so that we can redress our grievances to the our district first, and we have to further perform. That is, these are National Consumer Disputes Redressal Commissions known as National Commission, State Commissions, and Dispute Redressal Commissions, State Commission, District Consumer Dispute Redressal Forums, and many forums and meetings and committees will be held to address this Consumer Protection Act. At present, there are 34 state commissions, one in each state, and 571 district for besides the National Commission. Pecuniary jurisdiction criteria is also followed to conduct such forums. Procedural matters are period of limitation. That is, a complaint is only admitted by any of the competent forums under Consumer Protection Act if it is filed within 2 years from the date of which the cause of action has arisen. Any issue which is arise should be immediately reported to the CPA, or within a 2 years this should be reported to the concerned committee. Procedure to file a complaint. There are procedures to file this complaint. Complaint can be filed in the district forum first, and then to the state and to the national, or as per preconiary jurisdiction is another forum within the local limits of whose jurisdiction the opposite party or any business or any opposite party's residency resides or carries on business, or a branch office or personally works for this gain. Procedure followed by the consumer courts. Consumer courts proceeds to settle disputes as per section 13 by using the evidence brought by the complainant and opposite party, that is the patient and the doctor, or any medical profession and the patients, recipients or donors or anything. If a dispute between the medical practitioner and the patient, it should be settled immediately and should be proceeded to the consumer courts. Where opposite party denies or disputes the allegations contained in complaint, the main thing is basis of the evidence they'll give the law under the or they'll fail or omit. If they fail to accept their law, they'll be under the prosecution. By virtue of section 13, district forum has the same powers as vested in the civil court under the code of civil procedure while trying to suit a case. Vicarious liability, it is nothing but the thing speak for itself. That is a case study, which is the held that the hospital authority is liable for the negligence of doctors and surgeon employed by authority under a contract of service contract for service arising in the course of performance of their professional duties. Though hospital which is responsible for the doctors who are performing the liabilities and negligence, so that they are under the supervision of that doctor for a certain contract time. If the patient has suffered an injury in circumstance which are acceptable only as being attributed as part of the doctor, and rest of the thing will be alleged to the hospital name, in the name of hospital may be applied. The patient is then entitled to succeed unless the doctor can bring evidence to rebut the possibility of negligence. The doctrine may be used. The accident is for a kind which ordinarily does not occur in the absence of the negligence, and the apparent cause of the accident being within the control of the defendant, and also the plaintiff could not have contributed to it. Non-allopathy practicing allopathy. That is, if a person practices medicine without possessing any qualification or enrolled under if he or she is not enrolled under Indian Medical Council Act 1956, he or she became liable to be punished within the imprisonment or fine or both. So the Honorable Supreme Court is in Pune, Burma, has filed this as a law that if a person practices medicine without possessing his qualification or registered under Indian Medical Council, then he is under the medical negligence. Criminal liability for medical negligence. That is nothing but, in this thing, the law, that Suresh Gupta, Government of NCT of Delhi, has said that it was held that where a patient dies due to negligent medical treatment of the doctor can be made liable in civil law for paying compensation and damages in tort and at the same time. If the degree of negligence is so gross and his act was reckless as to endanger the life of the patient, he would also be made criminally liable for offense. That is under section 304 of IPC. Following are the most common medico-legal issues what we have seen is these are the following are the most common medical legal issues faced by doctors and healthcare personals. Medical legal issues concern advanced directions, that is living wills, blood samples or toxic substance, or some screens uttering treatments reportings child abuse. That is nothing but from this medical negligence. There are various types of medical negligence done by medical practitioners. That is nothing but using of toxic substances, and also blood sample supply is not properly done, and proper treatment at proper time is not done, proper care to the patient is not done, and also for reporting for the sexual abuse by the doctors to the patients, and else abuse sexual around duties, that is reporting duty doctors or uttering threats to the patients, or proper regulations not followed by the hospitals or by the medical health seniors, that is by physicians or neurosurgeons or any surgeons or anything, the allegations or anything done by the medical practitioners or any other field of medical, either by the nurses or medical practitioners or by wrong prescriptions, everything comes under the Medical Negligence Act. And medical and unfit certificates, yeah, fit certificates and unfit certificates given by the medical doctors, that is also comes under the medical negligence. The unfit peoples are provided with the fit, and this makes the society very into a wrong condition. That is nothing but unfit people should not be work in the industry or anything. Medical fit certificates are given for the commercial purpose, that is by collecting the money they are providing all medical fit certificates. And to operate a motor vehicles they are giving the fit certificates, even for the unfit peoples, that is the fraud medical unfit to operate a motor vehicles abuses. All these things comes under the Medical Negligence Act. Thank you. These are the things should be covered in the, we have covered in the Medical Negligence Act. Hope you have understood. With the case study I have given to you in examples. If you have any doubt in medical negligence and transplantation of organs law, kindly share in the chat box so that I can answer you. Do you have any doubts? Two topics are covered. Rest other topics will be neonatal diagnosis. All these things will be covered in the further classes. Do you have any doubt? Kindly post your doubts in the box, or any notes should be provided. Please kindly send. I'll send the PDF. Ma'am, can you hear me? Anyone can hear me?
Yes, ma'am.
Yes, I have concluded both the topics. If any doubts, please can you ask the questions or post the questions? Yes, by this I conclude my session for today's session. Thanks for listening and attending my class.
Thank you, ma'am.
Thank you.
Good afternoon, everyone. I am audible to you? Hello? Can anyone respond? I am audible to you? Can you hear me?
Yes, ma'am.
Thank you. Okay, good afternoon, everyone. I am Dr. Radhika. Today we are going to discuss about disaster management. These are some pictures of disasters. Disaster, it stands for D for detection, I for incident command, and S for safety and security. Assess, S for support, T for triage and treatment, evaluation and recovery. Now we can see the definition of a disaster. According to WHO, a disaster can be defined as any occurrence that causes a damage to a loss of human life or deterioration of a health and health service on a scale of sufficient to the warrant an extraordinary response from outside the affected community or area. Okay, hazard is any damage to the people or surrounding their environment. Emergency or a disaster do not only affect the health and well-being of a people, it lead to the large number of the peoples are killed or injured. Economical harm is also most common in a disaster. It can be occur at any particular place or any time. For example, like earthquakes, cyclones, these are the natural disaster. Some disaster we can predict before that it going to occur, like a cyclones and the floods. But like earthquakes, we cannot predict. Okay, there are two types of disaster. One is natural and another one is man-made. The man-made or technological, industrial, and then security related. And these are some other examples of the man-made disaster, like a fire, accident, biological disaster, chemical disaster, and nuclear disaster. And then terrorist attack. Okay, these are the some common natural disaster, like already I told volcano, tsunami, landslides, snowstorm. These are some examples you can see. And droughts is a long time no rain has occurred, so land get dried. Okay, these are the short-term effect of major natural disaster. Death is mostly common in earthquakes and in tidal waves. Severe injuries most commonly occur in earthquakes, and then communicable diseases most potential risk following all major disaster. And food shortage is most common in tidal waves and floods. Major population movements are most common occur in the tidal waves and floods. Okay, now we can see the phases of disaster management. These are some phases of disaster management: is disaster preparedness, disaster impact, disaster response, rehabilitation, and disaster mitigation. Okay, this is a disaster cycle. First, disaster impact, and then response, after that relief, and then rehabilitation or reconstruction. These phases are after the disaster phase, and then mitigation and preparedness are before the disaster phase. Okay. Now we can see the disaster impact and the response. First, once a disaster has occurred, we should search and rescue, and then we should give a first aid for the people. And then field care, triage, and then tagging and identification of the dead people. In field care, most injured person coverage spontaneously to the health facilities using whatever the transport is available. Bed availability and surgical service should be maximized, and provisions should be made for food and shelter. A center should be established to respond to inquiries from the patient's relatives and friends. And priority should be given to the victim identification, and adequate mortuary space should be provided. And triage. In triage consists of rapidly classify the injured patient on the basis of severity of their injuries. There are 4 color-coded system: red, yellow, green, and black. Red is the most high priority we will give, and then second one is yellow. It is a minor next moderate priority, and green ambulatory patient, they can walk and come, and black is a dead people. In triage, usually the principle of first come and first treated is not followed here in mass emergency. So we are treating among this color-coded system only in mass emergencies. These are the table for triage. In red, we give the top priority like a trauma and medical emergencies. Yellow is moderately injured patients, like a surgical emergency needed patients. In green, like minor injuries like a laceration or abrasion, like that the patient can walk and come. Black is dead body. It should be tagged, and then we should. Okay, identification of a body. First, you should remove the dead bodies from the disaster scene and shift to the mortuary and identify, and then you should reception of the bewared relatives. You should hand over to the relatives, responsible relatives, and we should tag the dead bodies in the tag name, age, place of origin, and triage of category, and diagnosis and initial treatment should be added in the tagging. Next we can see the relief phase. Relief phase is this phase means when the assistance from outside starts to reach from the disaster area. The type of disaster since a distant event having different effect on the population. The type and quantity of the supplies available locally. Initial emergency phase needed supplies will include food, blankets, clothing, and shelters. In relief phases, we should provide these to the people. There are 4 principal components. First one is acquisition of supplies, and second is transportation. If a patient got injured, we should transport them to a particular nearest healthcare centers. And storage, and third one is storage, fourth one is distribution. Okay, they will. Next is nutrition. Nutrition in infant, children, pregnant women, and sick person are more prone to a nutritional problem. After a certain type of disaster like hurricanes, floods, land or mudslides, volcanic eruption and sea urges involving more damage to the crops, stocks and food distributing system. Vaccination is not much needed in mass emergencies. They are now not recommended like typhoid and then cholera vaccines in mass vaccination. Tetanus also is not much needed. Next, we can see rehabilitation. In rehabilitation, the final phase in a disaster, it should be lead to a restoration of the pre-disaster condition. It starts from very first moment of the disaster. It includes a water supply, food safety, basic sanitation and personal hygiene, and then a vector control. In water supply, mainly we should see the quality, water quality for a microbial contamination. First priority for ensuring the water quality in emergency situation is chlorination. To increase the residual chlorine level about 0.2 to 0.5 mg per liter. This will low water pressure will increase the risk of infiltration of the pollutants into the water mains. Next, food safety. In food safety, poor hygiene is a major cause for the foodborne disease in a disaster situation. And in basic sanitation, communicable disease are more spread through the fecal contamination of a drinking water and in food. So in vector control, we have a control program for the vector-borne disease like dengue, malaria, leptospirosis, rat bite fever. These all will include. Next, disaster mitigation. Disaster mitigation, this involves lessening the likely effects of the emergencies. These include, depending upon the disaster, protection of vulnerable population structure. For example, improving the structural qualities of schools, houses, such other buildings, so that the medical casualties may be minimized. Similarly, ensuring the safety of the health facilities and the public health service, like including the water supply, sewerage system. These and all will reduce the cost of the rehabilitation and the reconstruction. This mitigation is, complements the disaster preparedness and then response activities. Next is disaster preparedness. Preparedness is usually regarded as comprising the measure which enable the governments, organization, communities, and individual to respond rapidly and effectively of a disaster situations. We can see some examples of the preparedness measures. First, we should evaluate the risk of the country or a particular region where the disaster has occurred. And then emergency communication. We should give a communication to the people when the disaster occurs, and to ensure the financial and other resources. Organize the communication and then information and warning system. If people's on seashores, we will give a warning system like that. If floods are coming, we will give some warning system. Develop a public education program, training program, and including a disaster simulation, exercise stress response mechanism. Next, we can see the principles of disaster management. In this, risk and hazards assessment. Second, planning. We should plan how to control the disaster management. Next, organization, resource utilization, and need for specialists, and then training. First, we can see risk and hazard assessment. A disaster risk will be a combination of likelihood of the event and the vulnerability of the place to that event. The hazard assessment will main aim to deliver the accurate disaster information about the individual or a particular location. Okay. Vulnerability to a particular hazards, what and all it will include, we can see it is a critical product, service, record, and operations. And second is hazards material and potential effects of damage on the stakeholder. and likely a financial cost, and resources personally and time available to make a preparation. And then level of insurance cover and then combinations of hazards and vulnerability, it will mainly result in the formulating of the total risk assessment. These all with this we can assess how much risk has been occurred. That vulnerability we can assess. Okay, now we can see planning. While planning, we should have a clear and logical approach what we are dealing with the disaster, and also to provide a common reference of all the department and authorities with the roles, and to assist with the information for setting up or a multi-fractional organization structure, and to form the basis for a coordinated actions, and you should provide a clear allocation for all the responsibilities, and to form a basis of reviewing and evaluating the current and future disaster management requirements, and at last we should give a focus for a disaster related training. Organization. We have some organization for a disaster management. For nature, we have a National Disaster Management Authority, and for utilization of a total government structure or resources, we have a national, state, and local level. National, state, and local levels, we have this organization, and then coordination of the non-governmental resource and community involvement and clear line of authority and unity of a command and special system requirement. Okay, special system requirement or a emergency operation centers or a control centers, and then direction and the coordinating authority and communications, warning system, survey and assessment, information management, and emergency logistics. These all the special system requirement. Okay, next we can see the resource utilization. For a resource, first we should identification of the resource, and then we should assess the resource with the relation to their capability and availability, and then allocation of a appropriate task. We should allocate the appropriate task, and then next is level of a skill in handling the allotted task and experience and activating the time for the deployment or availability. Coordination with the line authorities of a resource organization. At last is correlation of the accurate information for effective deployment of the resources. Okay, next we can see policy development. The formal statement course of an action. The policy is strategic in nature and perform the following function. It has some functions, we can see that. First, establish the long-term goal. Next, assign the responsibility for achieving the goal. And then establish the recommended work practice. At last, determine the criteria for the decision making. In this, it has 6 sectors for the response and recovery strategies. These are communication, health, social welfare, police, security, search and rescue, at last transport. These all the policy development. Okay, next we can see the personal protection. It has we should in different type of emergency, what and all we will for protect from that hazards we can see. Do not use the telephones except for the call for help, so as to leave the telephone line for free for the organization of response. Listen to the message broadcast by radio or a various media, so it has been informed of a development. Carry out the official instruction given over the radio or by loudspeaker. You should keep the family emergency kit ready. In all different types of emergency, it is better to be prepared than to get hurt. To get information so as to get organized, to wait rather than act too hastily. Okay. These are some pictures of floods, and this one is tornado. We can see what and all beforehand we can in floods beforehand, people who live in a downstream from a dam should know the special signals like a fog horns. These signals are given when the dams are threatened to break. Okay, after during a flood, what and all you should do? First, you should turn off the electricity as soon as the flood begins. Take a vulnerable people like infant, children, pregnant women, or old age people. You should then lift them to a upper floor. Be aware of the water contamination. And after flood, wait until the water is declared safe before drinking, and clean clean and disinfect any room that has flooded, and get rid of any food, even the canned food also that it near the water. Okay. In storms, hurricanes, or tornadoes, what and all precautions we have to do, we can see. Beforehand, choose a shelter in advance, like a basement, cellar, or in a cloud that may be perfectable, suitable. Minimize the effect of the storm. How will you minimize? By cutting the felled trees, prune tree branches. Regularly check the state of the roof and the ground. And then during emergency, do not go out in a car or a boat. Evacuate the house if authority requests. If possible, tie down any object liable to blown away by the wind. Open the window and door slightly on the side opposite to the direction from which the wind is coming, so it can reduce the pressure of the house. Okay. Anyone who is outside the house, first you should look for a shelter in a building. If keep away from the fences and the electric cables. After an emergency, follow the instructions that are given by the authorities. Stay indoors. Give the alert as quickly as possible. If anyone got injured, first give a first aid to them. Okay. In earthquake, what and all we will do? Beforehand, build in accordance with the urban planning regulation. Ensure that all the electrical and gas appliances in the house, together that with all the pipes are connected to them, are firmly fixed. Avoid the strong, heavy objects material in a high position. During an earthquake, you should not get panic. You should be calm. People who are in indoors should stay there, but move to the central part of the building, like under the table or a bed. People who are outside stay there, stay away from the building because it can be collide. After an earthquake, do not go back into the damaged buildings. Whoever got injured, same thing, we can give a first aid, and then emergency service should have been provided. In earthquake, only mostly high level of mortality has occurred. People being crushed by the falling objects. Mostly in a night time, people get fractures of pelvis, thorax, and spine. These are the most common. In daytime, arm and skull only mostly injured. Now, next, we can see the direction of disaster management. The National Disaster Management Authority has been set up as the apex body for the disaster management in India, with the Prime Minister as the chairman for the NDMA. And disaster management authorities will be set up at the state and district level. It will be headed by the Chief Minister and then collectors. Okay, these are this pyramid that we can see the level of the disaster management. And first one is national level, that is a national disaster management. It coordinates the response to any disaster. Second is the state and the local level. It manages the evacuation and basic supplies and then rehabilitation. And health authorities, they in emergency care at health facilities and public health issues. What and all this disaster causes effects means it causes the death of the people, disability of the people. It increases communicable disease. Communicable disease like malaria, typhoid, these are all more prone. And then it causes a overcrowding and poor sanitation also. Next is psychological problem and food shortage, socio-economic losses, and then shortage of the drug and medical supplies and environmental disruption. Okay, we can see what are the major disaster in India. Okay, on 3rd December 1948, Bhopal gas tragedy has been occurred. In that, 2 million people were exposed to the gas, leaving about 3,000 people dead. There are still people suffering from this side effects of the gas. And second is 2001 Gujarat earthquake. In that, about 16,000 people who have been died and lakh become homeless. 2004, we all know that Indian Ocean tsunami has occurred. In the 2 lakh people have been killed. And 2008, the Mumbai attack. And 2014, floods in Kashmir Valley. And then in April 26, 1986, we have a nuclear power station that had been nuclear power has been burst. In that, 7 million people have been 7 million people as curies of iodine 131. Okay. Next, we can see the nodal agencies for a disaster management. There are some agencies for a disaster management. First, Ministry of Agriculture. It will include all the activities during the natural disaster, whatever the floods or a cyclones, whatever, it will come under the Ministry of Agriculture. Indian Meteorological Department. Indian Meteorological Department play a key role in forewarning the disaster like cyclone and then earthquake. It has 5 centers in Kolkata, Bhubaneswar, Visakhapatnam, Chennai, and Mumbai for detection and tracing of the cyclones and the storms. It has a disaster warning system. It have been installed primarily in the coastal areas like Tamil Nadu and then Andhra Pradesh. And the snow and avalanche study establishment in Manali that issuing the warning to the people about 24 to 48 hours in advances. In India, we can see the vulnerability to the disaster. 57% of the land is vulnerable to the earthquake, and then 12% is a severe earthquake, and 68% land is mostly vulnerable to the drought. That is a dry land. Long term, they have no rain. And 12% land is vulnerable to the flood, and then 8% to the cyclones. Okay, Disaster Reduction Day has been on 2nd Wednesday of October. It has been celebrated. Okay, they have been provided some international agencies some health humanitarian assistance. It is a United Nations agency and non-governmental organization. In a United Nations agency, what and all it will come, we can see. Office for Coordination of Humanitarian Affairs, that is OCHA, and World Health Organization, we all know, and UNICEF, and then a Food and Agriculture Organization, and then a European Community Humanitarian Office. These are mainly Center for Coordination for Prevention of National Disaster in the Central America. Next, non-governmental organizations like Committee for Red Cross, that is a CARE, and International Council for the Voluntary Agencies, that is ICVA, and International Federation of Red Cross, and then Red Crescent Society, that is IFRC. These are some non-governmental organization. And some other disaster in India, we have a major earthquake in Jammu and Kashmir. About 30,000 people have been injured. More recently, we have in Uttarakhand cold burst as causing a flood that killed about 5,000 people in Kedarnath. Okay. Suppose in clouds of toxic forms, what and all before and we will see. People in a risk area should be evacuated as plants and facilities and familiarize themselves from the alarm signals that used in case of emergency. And then equip doors and windows with the tightest possible fastening should be there. And prepare the family emergency kits. During emergency, as usual, I told you should not use the telephone. You should leave the line free for rescue service, and we should listen to the message by radio and other media, and carry out the instruction transmitted by the loudspeaker or radio. You should close the doors and window. Organize a reserve of water by filling the wash basin, baths, etc. Turn off the ventilator and then air conditioner. These are some during the emergency of the clouds of toxic fumes. After the emergency, you can comply with the authorities' instruction and carry out the necessary decontamination measures. Okay. Because of this disaster, so many people become homeless and then they become malnutrition. Mainly, this deficiency because of the drought, the mortality may increase in the area where the drought causes famines, in which case there are many maybe a protein calorie malnutrition and vitamin deficiency, particularly a vitamin A deficiency, that can lead to a blindness of the people. In famine condition, the measles and the respiratory infections and diarrhea, this will lead to a dehydration. This mostly increases in infant mortality. When a people migrate or settle down on the outskirts of the famine area, poor hygiene and overcrowding may facilitate the spread of endemic communicable disease like tuberculosis, parasite disease, and then malaria. The relative number of the injuries and death differ depending upon the number of the factor like type of disaster and the density and the distribution of the population and condition of the environment and the degree of the preparedness and opportunity of the warnings. In this disaster, death exceeds this injury mostly in the explosion, earthquake, typhoons, hurricanes, tornadoes. If you have any doubt, you can ask me. Okay, now we can see the epidemiological surveillance and then disease control. A disaster can increases the transmission of the communicable disease. We can see some what are the points. First, overcrowding and then poor sanitation in a temporary restlessness. This account in part for the reported increase in acute respiratory tract infection like cough, cold, fever, disorder following the disaster. Next, population displacement. In this, mainly lead to the introduction of the communicable disease, to which either to the migrant or indigenous population, these peoples are more susceptible for this kind of communicable disease. And then disruption and the contamination of water supply. We already discussed that microbes can be contaminate the water during a floods. And also a damage to the sewage system and power system. These are all common in the natural type of disaster. And then a disruption of the routine control program. Routine control program like funds and the personnel are usually diverted to the relief work. And then ecological changes may favor the breeding of vector and increase the vector population density. And then displacement of the domestic and the wild animal who carry with them like a zoonosis that can be transmitted to the human as well as other animals. For example, leptospirosis cases have been reported following a large flood in Orissa after the super cyclone in 1999. Anthrax have been also reported occasionally. And then provision of emergency food, water, and shelter. These should be provided for the people from a different or a new source, maybe itself a source of infectious disease. And the outbreak of the gastroenteritis is most commonly reported in the post-disaster period. Okay, what are the principles for the preventing and control this type of communicable disaster? We can see. First, we should implement as soon as possible as a health measure to reduce the risk of disease transmission and organize to the reliable disease reporting system and to identify the outbreak and promptly initiate the control measures. And then we should investigate all the reports of the disease outbreak rapidly. Okay, these were the epidemiological surveillance and the disease of communicable space. If you have any doubt, you can ask me. In snowstorm, if a weather is cold, in this case of accidental hypothermia may occur. In cyclones, hurricanes, it has mortality is not high unless the tidal waves occur. It has a combined effect of the wind and rain. It may causes a house to collapse. A large number of the object also may lifted in the air and carried along by the wind. This give to rise of the injuries. Okay, major emergency and disaster have been occurred throughout the history and the world population that grows and resources become more limited. The community has increasingly become vulnerable to the hazards that causes a disaster. According to the statistics gathered in 1969, it showed a rise in the number of people that have been affected by the disaster, that increasing either in intensity or frequency. It can be concluded that vulnerability to a disaster is not getting down. It's day by day it's growing only. For each disaster, they have listed officially recognized disaster database. There are some 20 other small emergency with a destructive impact on the local communities. There are many as I put the slide, there are many types of disaster like a natural and man-made. Okay, I will tell about that one man-made disaster. One example. The latest example, that attack on a twin building of the World Trade Center in New York, in which about 6,000 people have lost their lives and thousands were being injured. And then this wars and civil conflicts, these all a man-made disaster only. Since World War II, there have been about 127 wars and 21.8 million war-related deaths involving more than 50% of the civilians. And then recently, the proportion of the civilians among the dead have been increasing only. And airborne power and wide-ranging nature of the modern war puts an entire population at risk, that used to a disruption of the food production or a supply routes, improving the fragile ecosystem and forcing the refugees by death in a current hostiles that resulted to the war-related famines. As for cause of most war, they most frequently objectives were gain of land, assist, and then independence. However, the civil war representing the power conflicts within the nations itself have increased sharply in the 20th century, and now by far the major form of the warfare. The public health response to a man-made disaster is mainly a primary prevention. First, prevention of occurrence of the disaster. Example, that much can be done to prevent not only the consequence but also the occurrence like a fire, explosion, crashes, sudden chemical and then radiation exposure. It also include the regulations of the chemical plant and other hazards facilities. That chemical be built away from the dense populous area. It should not be near the people who are living. It should be away from the people. And other measures include appropriate like engineering technological measures, the likely building codes, dam designs, containment of the toxic material, and early warning if possible and protection against human error. In the federal structure of India, the state government are responsible for the execution of the relief work, like in wake of the natural disaster. And government of India play a supportive role in the term of supplementation of the final resources to the state. And administrative system have been developed combat and minimize the disaster adverse impact of the natural disaster. Family welfare, there is a special wing called emergency medical relief wing that coordinates all activities that related to the health. In vast country like India, if it is not practicable for the government machinery alone to undertake the disaster, so it has a reduction program without involvement of the NGO. With NGO, it can with government NGO had been added, so the public education and the community involvements plays a vital role here. As part of the International Decade for a Natural Disaster Reduction Activities, we already told it's celebrated on the second Wednesday of the October. Okay. Okay, in disaster preparedness, I will tell one thing about the members of the community have been most to lose their been vulnerable to the disaster. So most of them to gain an effective and appropriate emergency preparedness program. They should everybody once a disaster occur, we should beforehand we should know what and all procedure we have to prevent the disaster. Those who first respond to an emergency come from within the community. When the transport and communications are disturbed, an external emergency response may not arrive for days. And then resources are most easily pooled at the community level. So every community possesses the capabilities. And then failure to exploit these capabilities is poor resource management. And then sustained development is the best achieved by allowing the emergency affected communities to design or manage or implement the internal and external assistance program. It has a multi-sectorial activity. It integrates the part of the national system that responsible for developing the plans program for disaster management or a prevention or a mitigation, preparedness response. We see rehabilitation and reconstruction this cycle. With this, we can control the disaster management. The emergency preparedness and the emergency management do not exist in a vacuum. To succeed this emergency program, that must be appropriate to their context. The context is vary from the this will be vary from country to country and also from the community to community. Okay. In addition to considering the action by rescues throughout, it must be given to a personal protection measure in a different types of emergency. I already told about the personal protection in different type of emergencies. We should making the people aware of that what is expected of them in case of emergency can make a large difference to that organized management effect. By taking these type of precautions, the individual can assist the collective effort to reduce the effects of the emergency. During that outbreak, most commonly gastroenteritis is most commonly reported disease in the post-disaster period. It usually close related to the first three factor. It increases the incidence of the acute respiratory infection. These are also most common in the displaced population. And I already told you about the vector-borne disease. It is mostly common, usually occur in the epidemic level. If epidemic level it occur, we should contact that control program for the vector-borne disease. The principles of preventing and controlling the communicable, I already discussed that. Okay. Okay. Thank you. If you have any doubt, you can ask me. Okay, thank you, everyone.
Good afternoon. Am I audible? Good afternoon.
Yes, ma'am.
Okay. Today, I will be discussing reservoir and mode of transmission. Before entering into the topic, how these diseases are transmitted, let us see. All communicable diseases are transmitted from the reservoir or source of infection to susceptible host. Basically, there are three links in the chain of transmission, namely the reservoir, the mode of transmission, and the susceptible host. Coming to the topic, reservoir. A reservoir is defined as any person, animal, arthropod, plant, soil, or substance in which an infectious agent lives and multiplies, on which it depends primarily for survival, and when it reproduces itself in such manner that it can be transmitted to a susceptible host. In short, the reservoir is the natural habitat in which the organism metabolizes and replicates. You should also know about what do you mean by source. The source of infection is defined as the person, animal, object, or substance from which an infectious agent passes or is disseminated to the host. The term reservoir and source are not always synonymous. For example, in hookworm infection, the reservoir is man, but the source of infection is the soil contaminated with infective larvae. In tetanus, the reservoir and source are the same, that is soil. In typhoid fever, the reservoir of infection may be a case or carrier, but the source of infection may be feces or urine of the patient or contaminated food, milk, or water. The term source refers to an immediate source of infection, may or may not be a part of reservoir. Till now, everyone understood? Am I audible?
Yes.
The term homologous reservoir is applied when another member of a same species is the victim. As for example, man is the principal reservoir for some enteric pathogen. Example, Vibrio cholera. The term heterologous is applied when the infection is derived from a reservoir other than man. As for example, animal, birds infected with salmonella. The reservoir may be of three types. One is the human reservoir, next is an animal reservoir, and another is a reservoir in non-living things. First, coming to human reservoir, the most important source of reservoir of infection for human is man himself. He may be a case or a carrier. Man is often described as his own enemy because most of the communicable diseases of which man is hired to contracted from human source. Coming to case, a case is defined as a person in the population or study group identified as having the particular disease, health disorder, or conditions under investigations. A variety of criteria, example, clinical, biochemical, laboratories, abstracts of clinical records, survey of the general population, population screening, and reporting of defects, etc., may be used to identify a case. Broadly, the presence of infection in a host may be clinical, subclinical, or latent. These variation in the manifestation of disease are referred to as spectrum of disease or gradient of infection. Before proceeding into the topic, we should know about what do you mean by the spectrum of disease. The spectrum of disease is a graphic representation of variation in the manifestation of disease. It is akin to the spectrum of light, where the color vary from one end to the other, but difficulty to determine where one color ends and other begins. At one end of the disease spectrum are subclinical infection, which are not ordinarily identified, and the other end are fatal illness. In the middle of spectrum lie illness ranging in severity from mild to severe. These different manifestations are simply reflection of individuals' different state of immunity and receptivity. For example, leprosy is an excellent example. For almost every disease, there exists a spectrum of severity with few exceptions such as rabies. In infectious disease, the spectrum of disease is also referred to as the gradient of infection. The sequence of events in the spectrum of disease can be interrupted by early diagnosis and treatment or by preventive measures, which, if introduced at a particular point, will prevent or retard the further development of the disease. The concept of spectrum of disease provides for inclusion of all cases, both subclinical and clinical, and in the study of disease. Clinical case. A clinical illness may be mild or moderate, typical or atypical, severe or fatal, depending upon the gradient of illness. Epidemiologically, mild cases may be more important source of infection than severe cases because they are ambulant and spread the infection wherever they go, whereas severe cases are usually confined to bed. Coming to subclinical case, the subclinical cases are variously referred to as inapparent, covert, missed, or abortive cases. They are equally important as source of infection. The disease agent may multiply in the host but does not manifest itself by signs and symptoms. The disease agent is eliminated and contaminates the environment in the same way as clinical cases. Persons who are thus sick contribute more than symptomatic patient to the transmission of infection to others, and what is more, they do not appear in any of the statistics. Subclinical cases play a dominant role in maintaining the chain of infection in the community. Subclinical infection can be detected only by laboratory tests, example, recovery of the organism, antibody response, biochemical and skin sensitivity test. Since subclinical infection occur frequently during a person's lifetime, they are responsible for the immunity shown by adult human to a variety of disease-producing microbes. Coming to latent infection. The term latent infection must be distinguished from subclinical infection. In latent infection, the host does not shed the infectious agent, which lies dormant within the host without symptoms, and often without demonstrable presence in blood, tissue, or bodily secretions of the host. For example, latent infection occur in herpes simplex, Brill-Zinsser disease, infection due to slow viruses, ankylostomiasis, etc. The role of latent infection in the perpetuation of certain infectious agent appears to be great. So in short, clinical illness is nothing but patient will be having a disease. In subclinical cases, it can be identified only by laboratory findings, and in latent infection, the infection which lies dormant within the host without any symptoms. Coming to certain terminology, the term primary case refers to the first case of the communicable disease introduced into the population unit being studied. The term index case refers to the first case to come to the attention of the investigator. It is not always the primary case. Secondary case are those developing from contact with primary case. A suspect case is an individual who has all of the signs and symptoms of a disease or conditions. It has not been diagnosed as having the disease or had the cause of the symptoms connected to the suspected pathogens. Coming to carrier. In some diseases, either due to inadequate treatment or immune response, the disease agent is not completely eliminated, leading to a carrier state. A carrier is defined as an infected person or animal that harbors a specific infectious agent in the absence of discernible clinical disease and serves as a potential source of infection for others. As a rule, carrier are less infectious than cases, but epidemiologically, they are more dangerous than cases because they escape recognition and continuing as they do not live a normal life among the population or community. They readily infect the susceptible individual over a wider area and longer period of time, and also under favorable condition. The very common example is typhoid Mary. What are all the elements in carrier states? One is the presence in the body of the disease agent, the absence of recognizable symptoms and signs of disease, the shedding of the disease agent in the discharges or excretion, thus acting as a source of infection for other person. Coming to classification of carrier, based on type, it is classified into incubatory carrier, convalescent carrier, healthy carrier. Based on duration, it is classified into temporary carrier and chronic carrier. And based on portal of exit, it is classified as urinary, intestinal, respiratory, and others. Coming to incubatory carrier are those who shed the infectious agent during the incubation period of disease. That is, they are capable of infecting others before the onset of illness. This usually occurs during the last few days of incubation period. Example, measles, mumps, polio, pertussis, influenza, and diphtheria. Convalescent carrier, that is, those who continue to shed the disease agent during the period of convalescence. Example, typhoid fever, dysentery, that is both bacillary as well as amoebic dysentery, cholera, diphtheria, and whooping cough. In these diseases, clinical recovery does not coincide with bacteriological recovery. A convalescent carrier can pose a serious threat to the unprotected household members and those in the immediate environment. As in the case of typhoid fever, patient who may excrete the bacilli for 6 to 8 weeks. This highlights the importance of bacteriological surveillance of carrier after clinical recovery. Coming to healthy carrier emerge from subclinical cases. They are victims of subclinical infection who have developed a carrier state without suffering from overt disease but are nevertheless shedding the disease agent. Example, poliomyelitis, cholera, meningococcal meningitis, salmonellosis, and diphtheria. It is well to remember that a person whose infection remains subclinical may or may not be a carrier. For example, in polio, the infection may remain subclinical and the person may act as a temporary carrier by virtue of shedding the organism. On the other hand, in tuberculosis, most persons with positive tuberculin test do not actively disseminate tubercle bacilli and therefore are not labeled as carrier. Based on duration, it is classified as temporary and chronic carriers. Temporary carrier are those who shed the infectious agent for a short period of time. In this category, it may include the incubatory, convalescent, as well as the healthy carrier. Chronic carrier is one who excrete the infectious agent for indefinite period. It occurs in number of diseases like typhoid fever, hepatitis B, dysentery, cerebrospinal meningitis, malaria, gonorrhea, etc. Chronic carrier are far more important sources of infection than cases. The longer the carrier stage, the greater the risk to the community. Some carrier excrete the infectious agent only intermittently and some continuously. The duration of the carrier state varies with the. In typhoid fever and hepatitis B, the chronic carrier state may last for several years. In chronic dysentery, it may last for a year or longer. In diphtheria, The carrier state is associated with infected tonsils, in typhoid fever with gallbladder disease. Chronic carriers are known to reintroduce diseases into areas which are otherwise free of infection, example malaria. Therefore, their early detection and treatment are essential to limit the spread of infection. Carriers of a virulent organism are called pseudocarriers. Pseudocarrier are not important epidemiologically. Based on portal of exit, carrier may be classified according to portal of exit of the infectious agent. Thus, we have urinary carrier, intestinal carrier, respiratory carrier, nasal carriers, etc. Skin eruption, open wounds, and blood are also portal of exit. In typhoid fever, the urinary carrier is more dangerous than an intestinal carrier. A typhoid carrier working in a food establishment or waterworks is more dangerous than a typhoid carrier working in an office establishment. Thus, the portal of exit and the occupational status of the carrier are important epidemiological considerations. So, in short, carrier may be classified based on type as incubatory, convalescent, and healthy carrier, based on duration into temporary and chronic carrier, based on portal of exit as urinary carrier, intestinal carrier, respiratory carrier, and others like nasal carriers, etc. Now coming to animal reservoirs. The source of infection may sometimes be animals and birds. These, like the human source of infection, may be cases or carriers. The disease and infection which are transmissible to man from vertebrates are called zoonosis. The best known example are rabies, yellow fever, and influenza. In this, the role of pigs and ducks in the spread of epidemic and pandemic influenza, both as reservoir, carrier, and amplifying host, is now well established. Pigeons in cities can lead to infection with chlamydia. Dust mites from them can cause allergy in man. Ornithosis and arboviruses can be transmitted to man from various birds. Wild bird in particular are important hosts in the transmission cycle of most of the mosquito-borne encephalitis and several mosquito-borne undifferentiated febrile diseases. Histoplasmosis is carried all over the world by birds. As birds migrate from one locality to another, they may carry ticks infected with viruses and rickettsia that may cause disease in humans. In short, the migration and the movement of animal and birds may carry serious epizootiological and epidemiological risk. There is evidence that genetic recombination between animal and human viruses might produce new strain of viruses, example influenza virus. Now coming to reservoir in non-living things, soil and inanimate matters can also act as a reservoir of infection. For example, soil may harbor agents that cause tetanus, anthrax, coccidioidomycosis, and mycetoma. Till now, everyone understood? Till now, everyone understood?
Yes, ma'am.
Okay. Now coming to mode of transmission. Communicable diseases may be transmitted from the reservoir or source of infection to a susceptible individual in many different ways, depending upon the infectious agent, portal of entry, and the local ecological conditions. As a rule, an infectious disease is transmitted by only one route. Example, typhoid fever by vehicle transmission and common cold by direct contact. But there are other which may be transmitted by several routes. Example, AIDS, salmonellosis, hepatitis B, brucellosis, Q fever, tularemia, etc. The multiple transmission routes enhance the survival of infectious agent. The mode of transmission of infectious disease may be classified as direct transmission and indirect transmission. In direct transmission, mainly by direct contact, droplet infection, contact with soil, inoculation into skin or mucosa, and transplacental. It is also known as vertical transmission. Indirect transmission is by vehicle-borne, vector-borne, airborne, fomite-borne, unclean hands and fingers. In vector-borne, it may be mechanical or biological. Airborne may be droplet nuclei or dust. First, coming to direct transmission, mainly by direct contact. Infection may be transmitted by direct contact from skin to skin, mucosa to mucosa, or mucosa to skin of the same or another person. This implies direct and essentially immediate transfer of infectious agent from the reservoir or source to a susceptible individual without any intermediate agencies. Example, skin to skin contact, as by touching or continued close contact. Direct contact not only reduces the period for which the organism will have to survive outside the human host, but also ensures a larger dose of infection. Disease transmitted by direct contact include sexually transmitted diseases and AIDS, leprosy, leptospirosis, skin and eye infections. Now coming to droplet infection, this is direct projection of a spray of droplet of saliva and nasopharyngeal secretions during coughing, sneezing or speaking, as well as talking into the surrounding atmospheres. The expelled droplets may impinge directly upon the conjunctiva, ororespiratory mucosa or skin of close contact. Particles of 10 mm or greater in diameter are filtered off by nose. Those 5 mm or less can penetrate deeply and reach the alveoli. The droplet spread is usually limited to the distance of 30 to 60 cm between source and the host. In infectious diseases, these droplets, which may contain millions of bacteria and viruses, can be a source of infection to others. When a healthy susceptible person comes within the range of these infection droplet, he is likely to inhale some of them and acquire infection. Disease transmitted by droplet spread include many respiratory infections, eruptive fevers, many infection of nervous system, common cold, diphtheria, whooping cough, tuberculosis, meningococcal meningitis, etc. The potential for droplet spread is increased in conditions of close proximities, overcrowding, and lack of ventilation. Coming to contact with soil, the disease agent may be acquired by direct exposure of susceptible tissue to the disease agent in soil, compost, or decaying vegetable matters in which it normally leads a saprophytic existence. Example, hookworm larvae, tetanus, mycosis, etc. Then inoculation into skin or mucosa. The disease agent may be inoculated directly into the skin or mucosa. Example, rabies virus by dog bite, hepatitis B virus through contaminated needle and syringes, etc. Then last is transplacental or vertical transmission. Disease agent can be transmitted transplacentally. This is another form of direct transmission. Example, torch agents. One is T for Toxoplasma gondii, O for others, R for rubella virus, C for cytomegalovirus, and H for herpes virus. Others like varicella virus, syphilis, hepatitis B, Coxsackie B, and AIDS. Some of the non-living agents like thalidomide, diethylstilbestrol can also be transmitted vertically. In these cases, the disease agent produces malformation of the embryo by disturbing its development. Okay. So, direct transmission, one is by direct contact. Next is by droplet infection. Next is by contact with soil. Next is inoculation into skin or mucosa, and last one is transplacental or vertical transmission. Coming to indirect transmission, this embraces a variety of mechanisms, including the traditional 5F, that is flies, fingers, fomites, food, and fluid. An essential requirement for indirect transmission is that the infectious agent must be capable of surviving outside the human host in the external environment and retain its basic properties of pathogenesis and virulence till it finds a new host. This depends upon the characteristics of the agent, the inanimate object, and the influence of transmitted in the vehicle. Example, hepatitis A virus in water. Diseases transmitted by water and food include chiefly infection of the alimentary tract. Example, acute diarrhea, typhoid fever, cholera, polio, hepatitis A, food poisoning, and intestinal parasites. Those transmitted by blood includes hepatitis B, malaria, syphilis, brucellosis, trypanosomiasis, infectious mononucleosis, and cytomegalovirus infection. Organ transplantation may result in introduction of the disease agent such as cytomegalovirus in association with kidney transplant. The epidemiological features of vehicle transmission are: if the dose of the contamination is heavy, the outbreak may be explosive, as in the case of cholera and hepatitis A epidemic. Cases are initially confined to those who are exposed to contaminated vehicle in some infection. When secondary cases occur, the primary case may be obscured. The distance traveled by the infectious agent may be great. Example, outbreak of food poisoning. It is not always possible to isolate the infectious agent in the incremented vehicle. Example, typhoid bacilli in contaminated water. When the vehicle is controlled or withdrawn, the epidemic subsides. Example, epidemic of cholera. The common source of infection is often traceable. Vector-borne. In infectious disease epidemiologically, vector is defined as an arthropod or any living carrier, example snail, that transports an infectious agent to the susceptible individual. Transmission by a vector may be mechanical or biological. In the latter case, the disease agent passes through a developmental cycle or multiplication in the vector. Epidemiological classification of vector-borne diseases it is classified based on invertebrate type and vertebrate type. Invertebrate type arthropod vector fall into 7 orders largely. One is Diptera, that is flies and mosquitoes. Next one is Siphonaptera, that is fleas. Next is Orthoptera, that is cockroaches. Next one is Anoplura, that is sucking lice. Next is Hemiptera, that is bugs, including kissing bugs. Next one is Acarina, that is ticks and mites. And last one is Copepoda, that is cyclops. Coming to vertebrate types, this is mice, rodents, and bats. Based on transmission chain, one is by man and a non-vertebrate host. Next is man, another vertebrate host and a non-vertebrate host. And last one is man and 2 intermediate hosts. First, coming to man and a non-vertebrate host. One is man, arthropod, man, that is malaria mainly. Next is man, snail, and man, that is schistosomiasis. Coming to man, another vertebrate host and a non-vertebrate host. In this, mammal is transmitting disease to arthropod, and then this arthropod is transmitting disease to man, that is plague. Next is bird, that will transmit disease to arthropod and that will transmit to man, that is encephalitis. Next one is man and two intermediate hosts. Man acquired infection by cyclops and also fish, and then again to man, that is fish tapeworm. Another example is snail, fish to man, that is Clonorchis sinensis. Next is man, snail, crab, man, that is Paragonimus. Another method in which vector transmit, one is by biting, next is regurgitation, next is scratching of infective feces, and last one is contamination of host with body fluids of vector. Last, by method in which vector are involved in the transmission and propagation of parasites. What are all the methods? One is the mechanical transmission, another one is a biological transmission. Coming to mechanical transmission, the infectious agent is mechanically transported by a crawling or flying arthropod through soiling of its feet or proboscis, or by passage of organism through its gastrointestinal tract and passively excreted. There is no development or multiplication of infectious agent within the vector. Next is biological transmission. The infectious agent undergoing replication or development or both in vector and require an incubation period before vector can transmit. Biological transmission is of three types. One is propagative, next one is cyclopropagative, and last one is cyclodevelopmental. First, coming to propagative, the agent merely multiplies in vector but no change in form. Example is plague bacilli in rat fleas. Next is cyclopropagative. The agent changes in form as well as in number. That is malaria parasite in mosquito. And last is cyclodevelopmental. The disease agent undergoes only development but no multiplication. Example, microfilaria in mosquito. When the infectious agent is transmitted vertically from the infected female to her progeny in the vector, it is known as trans-ovarian transmission. Transmission of disease agent from one stage of the life cycle to another, as for example, nymph to adult, is known as transstadial transmission. What are all the factors which influence the ability of vector to transmit diseases? One is host feeding preference. Next one is infectivity, that is ability to transmit the disease agent. Next is susceptibility, that is ability to become infected. Next is survival rate of vector in the environment. Next is domesticity, that is degree of association with man. And next is suitable environmental factor. Seasonal occurrence of some diseases, example malaria, may be related to intense breeding and thereby greater density of the insect vector during certain period of the year. So, vector borne is classified as one based on by vector into invertebrate type and vertebrate type based on chain of transmission. One is by man and non-vertebrate host. One is by man and another vertebrate host and a non-vertebrate host. And last one is man and two intermediate hosts. And then by method in which vector transmitting agent like biting, regurgitation, scratching in, and contamination of host with body fluids or vector. And last one, by means of mechanical transmission and biological transmission. In biological transmission, it is of three types. One is propagative, next one is cyclopropagative, and last one is cyclodevelopmental. Propagative means the vector will multiply, but there is no change in form. That is example is plague. Cyclopropagative, the agent multiply both in form as well as in number, that is malaria. And last one is cyclodevelopmental. It will change in form only, but no multiplication. That is microfilaria. And another two types of transmission, one is trans-ovarian transmission and another one is transstadial transmission. Okay. Till now, everyone understood? Till now, everyone understood? Am I audible?
Yes, ma'am. Yes, ma'am.
Okay, now coming to airborne. Airborne mainly by droplet nuclei and another one is dust. Droplet nuclei are a type of particle implicated in the spread of airborne infection. They are tiny particles, that is 1 to 10 micron range, that represents the dried residue of droplets. They may be formed by evaporation of droplet, coughed or sneezed into the air. Next is generated purposefully by a variety of atomizing devices, that is aerosol. They may also be formed accidentally in microbiological laboratories, rendering plants or autopsy rooms, etc. The droplet nuclei may remain airborne for long period of time, some retaining and others losing infectivity or virulence. They not only keep floating in the air, but may be disseminated by air currents from the point of their origin. Particles in the 1 to 5 micron range are liable to be easily drawn into the alveoli of the lung and may be retained there. Disease spread by droplet nuclei include tuberculosis, influenza, chickenpox, measles, Q fever, and many respiratory infections. Coming to dust. Some of the large droplets which are expelled during talking, coughing, sneezing settle down by their sheer weight on the floor. Carpets, furniture, cloths, bedding, linens, and other objects in the immediate environment and become part of the dust. A variety of infectious agents, example streptococci, other pathogenic bacteria, viruses, fungal spores, and skin squamine have been found in the dust of hospital wards and living rooms. Some of them, example, tubercle bacilli, may survive in the dust for considerable period under optimum condition of temperature and moisture. During the act of sweeping, dusting, and bed making, the dust is released into the air and becomes once again airborne. Dust particles may also be blown from the soil by wind. This may include fungal spores. Coccidioidomycosis is an example of a disease spread through airborne transmission of fungal spore. Other diseases carried by infected dust include streptococcal and staphylococcal infection, pneumonia, tuberculosis, Q fever, and psittacosis. Airborne dust is primarily inhaled but may settle on uncovered food and milk. This type of transmission is most common in hospital-acquired or nosocomial infections. So, airborne infection is mainly transmitted by droplet nuclei, and next one is dust. Nosocomial infection we have already discussed. It is classified into surgical site infection, urinary infection, respiratory infection, vascular catheter infection, and septicemia. The most common is urinary tract infection. And this nosocomial infection is also considered in three angles. One is based on source, next one is based on route of spread, and based on recipients. Based on source, it is mainly based on the patients or staffs or environment. And route of spread is one is direct contact, next one is droplet infection, next is airborne particle, next is release of hospital dust into air, next through hospital procedures, namely catheterization, infected catgut sutures, sputum cups, dressings, etc. How they are prevented? They are mainly prevented mainly by isolation, by hospital staffs. Next one is hand washing, that is very important. Next is dust control, disinfection, control of droplet infection, nursing technique, and administrative measures. That is mainly control of infection committee. Okay. The standard precaution for nosocomial infection is wearing a gown, glove, mask, etc. And before doing any procedure, hand washing is must. Okay. Now coming to fomite borne. Fomite or inanimate articles or substance other than water or food contaminated by the infectious discharges from a patient and capable of harboring and transferring the infectious agent to a healthy person. Fomites include soiled cloths, towels, linen, handkerchief, cups, spoon, pencils, books, toys, drinking glasses, door handles, taps, lavatory chains, syringes, instruments, and surgical dressing. The fomites play an important role in indirect transmission. Disease transmitted by fomites include diphtheria, typhoid fever, bacillary dysentery, hepatitis A, eye and skin infection. And last one is unclean hands and fingers. Hands are the most common medium by which pathogenic agents are transferred to food from the skin, nose, bowel, etc., as well as from other foods. The transmission takes place both directly as well as indirectly. Directly by hand to mouth. Example include staphylococcal and streptococcal infection, typhoid fever, dysentery, hepatitis A, and intestinal parasites. Unclean hands and fingers imply lack of personal hygiene. Lack of personal hygiene coupled with poor sanitation favor person-to-person transmission of infection. It is an example. In 1984, there is a dysentery epidemic in India. That is a very common example for unclean hands and fingers. So, the indirect transmission include vehicle-borne, vector-borne, airborne, fomite-borne, and unclean hands and fingers. Vehicle-borne is mainly by infectious agent by the agency of water, food, blood, serum, plasma, other biological products. Vector-borne, it is again classified into invertebrate type and vertebrate type based on chain of transmission as man and a non-vertebrate host, man and another vertebrate host and a non-vertebrate host, and last one is man and two intermediate hosts. By means mainly by transmitted mainly by biting, regurgitation, scratching, or contamination of host with body fluids of vector. And last is by mechanical transmission or biological transmission. In biological transmission, it is again divided into cyclopropagative, cyclodevelopmental, and propagative. And also by transovarian transmission and transstadial transmission. And next one, coming to airborne. Airborne is classified as droplet nuclei and dust. And next is fomite-borne. Fomite-borne is mainly by inanimate articles. One is by direct contact or indirect contact. And last one is unclean hands and fingers. That's all. So in short, mode of transmission is mainly direct transmission, indirect transmission. Any doubts? Any doubts regarding reservoir and mode of transmission?
No, ma'am.
Okay. Okay, I'll end up the session. Thank you. Thanks to Director Sir for giving me this opportunity. Thank you for all the participants.
Thank you, ma'am.
Thank you, ma'am.